My name is Fernando Florido and I am a GP in the United Kingdom. Now think, after seeing a patient, have you ever found yourself wondering whether you may have missed an important diagnosis? And what if it is cancer? Are you sometimes unsure about cancer red flags and how you should manage those patients? I know that I have, and if you have too, then you're in the right place. Because with this episode, we're starting a new cancer series that will help you in this respect. In this video, I will go through a section of the NICE guideline Suspected Cancer, Recognition and Referral, which was published in 2015 and was last updated in December 2021. This episode will cover lung cancers and mesothelioma as well as gastrointestinal cancers. I hope that you enjoy this video. In this episode, I will go through a section of the NICE guideline NG12, which is Suspected Cancer, Recognition and Referral, which was published in June 2015 and it was last updated in December 2021. This episode will cover lung cancer and mesothelioma as well as gastrointestinal tract cancers. I hope that you enjoy the episode. We're going to start with the respiratory cancers, that is lung cancer and mesothelioma. The recommendations in respect of lung cancer and mesothelioma are described separately in the NICE guideline. However, as it can be expected, there is significant overlap between the red flags for the two conditions, and therefore, for simplicity and avoidance of repetition, I have amalgamated both recommendations into one. These recommendations say the following. We must refer people using a suspected cancer pathway referral, which in the UK means an appointment within 2 weeks, for lung cancer or mesothelioma if they have a chest X-ray that suggests lung cancer or mesothelioma, or if they're aged 40 and over with unexplained hemoptysis. I understand this to be that we would need to refer someone over 40 with unexplained hemoptysis even before doing a chest X-ray, or if it has already been done, even if it is normal. Now, we must offer an urgent chest X-ray, and that is also to be done within 2 weeks, not a full cancer referral, but an urgent chest X-ray to assess for lung cancer or mesothelioma in people over 40 if they have 2 or more of the following unexplained symptoms, or they have 1 or more of the following unexplained symptoms and they have ever smoked, or if they have 1 or more of the following unexplained symptoms and have been exposed to asbestos. I'm going to repeat that again. We must offer an urgent chest X-ray to be done within 2 weeks to assess for lung cancer or mesothelioma in people aged 40 and over if they have 2 or more of the following unexplained symptoms, or if they have 1 or more of the following unexplained symptoms and have ever smoked, or they have 1 or more of the following unexplained symptoms and they have been exposed to asbestos. And these symptoms are cough, shortness of breath, chest pain, fatigue, weight loss and appetite loss. While the first 3, cough, shortness of breath and chest pain, may appear evident, the last 3, that is fatigue, weight loss and appetite loss, may not always prompt us to think about lung cancer. Now, these are the cases where we must refer patients for a chest X-ray. However, we need to consider, as opposed to must, request an urgent chest X-ray, that is to be done within 2 weeks as well, in people over 40 with any of the following: persistent or recurrent chest infection, finger clubbing, supraclavicular lymphadenopathy or persistent cervical lymphadenopathy, chest signs consistent with lung cancer or pleural disease, and thrombocytosis. So we should consider a chest X-ray for people over 40 with any of those symptoms. Now we're going to move to the gastrointestinal tract cancers, both upper and lower parts of the gastrointestinal tract. In terms of esophageal and stomach cancers, obviously we must consider a suspected cancer pathway referral again for an appointment within 2 weeks, for people with an upper abdominal mass consistent with stomach cancer. We must offer urgent direct access upper gastrointestinal endoscopy, so that is a 2-week referral for endoscopy, not for cancer referral as such, to assess for esophageal and stomach cancers in people with dysphagia, or if they're aged 55 and over, with weight loss and any of the following: upper abdominal pain, reflux and dyspepsia. So it's either dysphagia or aged 55 and over and weight loss, and either upper abdominal pain, reflux or dyspepsia. We need to consider non-urgent direct access upper gastrointestinal endoscopy to assess for esophageal or stomach cancer in people with hematemesis. Obviously, I understand that the urgency of the referral will be guided by our clinical judgment depending on the severity of the hematemesis. We also need to consider non-urgent direct access upper gastrointestinal endoscopy in people aged 55 or over with one of these: treatment-resistant dyspepsia, or upper abdominal pain with low hemoglobin, or raised platelet count with any of the following: nausea, vomiting, weight loss, reflux, dyspepsia, and upper abdominal pain. Or nausea and vomiting with any of the following: weight loss, reflux, dyspepsia, upper abdominal pain. So looking at it again is 55 and over with treatment-resistant dyspepsia, upper abdominal pain and low hemoglobin, raised platelet count with nausea, vomiting, weight loss, reflux, dyspepsia or upper abdominal pain, or nausea and vomiting with weight loss, reflux, dyspepsia, upper abdominal pain. But this is for non-urgent endoscopy. Now, when it comes to pancreatic cancers, we must refer people using a suspected cancer pathway referral for pancreatic cancer if they're aged 40 or over and have jaundice. That's fairly clear. We need to consider an urgent direct access CT scan to be done within 2 weeks, or an urgent ultrasound scan if CT is not available, to assess for pancreatic cancer in people aged 60 and over with weight loss and any of the following: diarrhea, back pain, abdominal pain, nausea, vomiting, constipation, new onset diabetes. So that would be urgent CT scan for people over the age of 60 with weight loss and basically another digestive symptom. That could be diarrhea, abdominal pain, nausea, vomiting, constipation, as well as back pain and new onset diabetes. I would personally say that if you do not have direct access to CT scan, you should not be entirely reassured by just an ultrasound scan, and perhaps a referral for further investigation should be in order if the symptoms are significant. Now, in terms of gallbladder and liver cancers, we need to consider an urgent direct access ultrasound scan, again to be done within 2 weeks, for assess for gallbladder or liver cancer in people with an upper abdominal mass consistent with an enlarged gallbladder or liver. Now, when it comes to colorectal cancer, we must refer adults using suspected cancer pathway referral, that is for an appointment within 2 weeks, for colorectal cancer if they're aged 40 and over with unexplained weight loss and abdominal pain, aged 50 and over with unexplained rectal bleeding, or they're aged 60 and over with iron deficiency anemia or changes in the bowel habit, or the patient tests show occult blood in the feces, and it seems that the guideline indicates this irrespective of age. So, repeat again, we must refer on cancer pathway 40 and over with weight loss and abdominal pain, 50 and over with rectal bleeding, 60 and over with iron deficiency or changes in bowel habit, or irrespective of age, if the tests show occult blood in their feces. These are when we must refer. However, we need to consider a suspected cancer pathway referral. For patients with a rectal or abdominal mass, fairly straightforward. We also need to consider a suspected cancer pathway referral in adults aged under 50 with rectal bleeding and any of the following unexplained symptoms: abdominal pain, change in bowel habits, weight loss, iron deficiency anemia. So that means anybody under 50 with rectal bleeding and some of the symptoms, we should consider the cancer pathway referral. This means for any other patient not meeting the must refer age requirement, then we should consider it. We can also offer testing with quantitative fecal immunochemical tests to assess for colorectal cancer in adults without rectal bleeding who are age 50 and over with unexplained abdominal pain or weight loss, aged under 60 with change in the bowel habits or iron deficiency, or 60 and over and have anemia even in the absence of iron deficiency. Now finally, the last one of the gastrointestinal tract cancers is anal cancer, and we need to consider a suspected cancer pathway referral for anal cancer in people with an unexplained anal mass or unexplained anal ulceration. This is the end of this video and the summary of this section of the guideline. If you have found it useful, please make sure that you hit the like and subscribe buttons. There's also a podcast version in the Clinical Guidelines in Primary Care podcast, which you can find on your favourite podcast provider. I will leave a link in the description below, and there you will also find the link to the full NICE guideline. Thank you for watching, and I hope that you will join me in the next one.